Welcome back, guys. Today we're gonna talk about the inflammatory bowel disease. We have two types of inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. Before that, we're gonna make a rapid review for the layers of the GIT tract. We have from outer side we have a serosa adventitia. Most inner to it is the muscularis, and we have a submucosa, and the most inner one it is the mucosa. As we said before, it is an inflammatory disease. So the Crohn's disease, it is an inflammation affect all these four layers. That's why we call it transmural inflammation. But ulcerative colitis just affect the mucosa and submucosa only. Also, we call Crohn's disease an escape lesion, which is mean that there is an affected area and we have a normal area just next to it. But ulcerative colitis, it is a continuous disease. That means that the infection all the way down the GIT get infected. About the anatomy, the rectal is normal in the Crohn's disease, but always the rectal get infected in the ulcerative colitis. Through the X-ray, after applying the barium swallow, we have a sign called string sign. But in the ulcerative colitis, we call it a lead pipe sign. We're gonna take a look for this picture down there. Here we see the lead sign here. You see this line, it is a line called a string sign. This is the normal picture for the GIT tract. We have seeing the normal blood supply here and here and here. It's easy to see, and there is no hyperemesis or redness or swelling or necrotizing happening there. Let's take a look to the picture just next to it. We have here a disease. Let's figure out what is this disease. This disease, we have an affected area all the way down. I cannot see any area with a normal blood supply here, and we see affected area here and here and here and here. Also, this whiteness is inflammation. Also, this black one inflammation. The inflammation, there is no normal area. That means this is most probably this is an ulcerative colitis. We have to take a look through the other layers of the tract to see if it's transmural or just affecting the mucosa or submucosa. If it affected the mucosa or submucosa, it will be the ulcerative colitis, but if it transmural affect all the layers, it will be ulcerative colitis. Here we have the complication. We have a major complication with sharing this both disease. We have a malabsorption and malnutrition. We have a colorectal cancer. We have colorectal cancer increased risk with the pancreatitis. We have a unique features for those two diseases. We can suggest this is an ulcerative colitis or this Crohn's disease by seeing this thing. Before the complication, we have to see the microscopic morphology. There is a unique feature for the Crohn's disease, which is non-caseating granuloma. That means there is a granuloma without a necrotic center. But in ulcerative colitis, we have an ulcer with uncrept abscesses. So we have abscess. If we know this patient have an abscess, this is 100% is not Crohn's disease. It is an ulcerative colitis. But if the patient has a fistula, it's 100% Crohn's disease, because the fistula not happen with the ulcerative colitis and the abscess it not happen with a Crohn's disease. So as I said, the fistula is connection between the two epitheliums. So this fistula, common fistula, happening with the Crohn's disease, it is enterovesical fistula. which is a fistula between the GIT tract and the urinary bladder, which can cause a recurrent UTI because the GIT content will appear in the urinary bladder with its bacteria, normal flora, and blah blah blah. Also, we have an hematuria because the gallbladder have the GIT has air on it, so that may the air get through this fistula and present in the urinary bladder, thus causing an hematuria. Also, Crohn's disease have a plasmin and abscesses. Okay, so we have another abscess here. So what's the difference between the abscess in ulcerative colitis and the abscess in the Crohn's disease? So we said it's a crypt abscess of the crypt of the intestines. But here the abscess of the Crohn's disease is not in the crypt. That's the difference. Also the plasmin, this is the infection of the inflammation of the soft tissue. Also, we have a stricture causing obstruction and renal disease. The stricture will happen in the Crohn's disease because it affects the transmural layers. That's why this causes the thickening of the wall and make the lumen lesser in diameter. Also, we have an bloody diarrhea and ulcerative colitis, which is not bloody in the Crohn's disease. And we have an external manifestation, extra-intestinal manifestation of those diseases. The rash and the eye inflammation and oral ulceration and arthritis, it's usually in both Crohn and ulcerative colitis. But kidney stones and gallbladder stones, it's just specific for the Crohn's disease. And primary sclerosing cholangitis, which is sclerosing of the biliary tree, it is just for the ulcerative colitis, associated with the B ANCA and the ulcerative colitis, and may be associated with ASCA in Crohn's disease. ASCA, which is stand for the anti-Saccharomyces cerevisiae antibody. The treatment for those disease is a corticosteroid and azathioprine and antibiotic like ciprofloxacin and metronidazole and biologic infliximab and adalimumab for Crohn's disease. But in the ulcerative colitis, we have an amino salicylic preparation with a mesalamine and 6-mercaptopurine and infliximab and cholecystectomy. Also here they put some monomers to easy to memorize those disease. Ulcerative colitis, they make a monomer for ulcers. Ulcers here, U stand for ulcer, L for large intestine, C for continuous colorectal carcinoma and crypt abscess, E for extends proximally, R for red diarrhea, bloody diarrhea, and the last one is sclerosing cholangitis. And for Crohn's disease, think for fatty granny and old Crohn skipping down the cobblestone road away from where it's so difficult. It's difficult than the disease itself. I don't like this one. It's still more common in the Crohn. Yeah, stones more common in Crohn's. That's easy to memorize. That's gallstones and kidney stones, usually calcium oxalate. It is associated with Crohn's disease.